Hello, everyone, and welcome to today's webinar, Optimize Sepsis Testing with Culture-Independent Diagnostics. And I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by T2 Biosystems. To learn more, visit them at t2biosystems.com. Now, we encourage you to participate today by submitting as many questions as you want during this presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have any trouble seeing or hearing this presentation. Now, before we continue, I also want to encourage you to participate in the poll questions. Please take a moment to answer the questions in the display on your screen. You'll see them. This webinar is educational, and this offers free education credits. Please visit the continuing window at the bottom of your screen to obtain those credits. I'd now like to welcome our speakers, Dr. Aparna Ahuja, Chief Medical Officer at T2 Biosystems, and Dr. James Snyder, Professor of Pathology and Laboratory Medicine at University of Louisville and Medical Director of the Clinical Microbiology and Molecular Diagnostics Laboratory at University of Louisville Hospital. Dr. Denise Uettwiller-Geiger at the Clinical Transformation, she's a Clinical Transformation Liaison and Clinical Chemist at Mather Hospital and Northwell Health. Welcome to all of you, and now I'd like to encourage our audience members to take our poll. Our first poll question is, how would you rate the level of priority to improve the diagnosis of sepsis at your institution? Please take a minute to answer this question for us. And our next question is, sepsis-causing bacterial pathogen is most prevalent at your institution. Which one? Please take a minute and answer this question as well. And at this time, I want to thank you again for joining us today. Aparna, James, Denise, welcome. You may now begin your presentation.
Thank you. Just wanted to confirm whether you could see the presentation. Good morning, everyone. Thanks for participating in this session. I'm really excited to be discussing this very important topic, optimizing sepsis testing with culture-independent diagnostics. Sepsis is the body's extreme response to an infection and is a potentially life-threatening medical emergency, and early treatment improves chances of survival. So on that note, we know that sepsis is a burdensome condition across the world in terms of morbidity, mortality, and health care cost. Sepsis represents $62 billion in U.S. healthcare cost, claims more lives each year than 3 leading causes of cancer deaths combined. And CDC data states that each year, 1.7 million adults in U.S. develop sepsis. 270,000 Americans die as a result of sepsis. 1 in 3 patients who dies in a hospital has sepsis. Another concerning fact is that the hospitalized COVID patient as compared to hospitalized influenza patient faces a 22% higher risk of developing sepsis and is 113% more likely to experience septic shock. Antimicrobial resistance is on the rise globally and is one of the biggest public health challenges of our time. CDC reports that each year in the US, more than 2.8 million people get an antibiotic-resistant infection and more than 35,000 die. That means on an average, someone in the US gets an antibiotic-resistant infection every 11 seconds, and every 15 minutes, someone dies as a result. Antimicrobial resistant infections are estimated to cause 1.27 million deaths annually worldwide. And as mentioned by Dr. Tedros Ghebreyesus, the Director General of World Health Organization, COVID-19 pandemic has led to an increased use of antibiotics, which ultimately will lead to higher bacterial resistance rates that will impact the burden of disease and deaths during the pandemic and beyond. And we are seeing that happening as of today. The concerns with antimicrobial resistance is I would say there are multiple concerns, and one fact is that although it has been proven that prevention and infection control efforts can reduce deaths from antibiotic-resistant infections, the number of people facing antibiotic resistance is still too high. There's lack of early detection of pathogen or confirmation of absence of certain pathogen leads to prolonged empiric therapy, which also contributes to the emergence of antimicrobial resistance. Overprescribing antimicrobial leads to emergence and spread of antimicrobial resistance. And in this situation where the early detection is challenging, overprescribing is seen as being acceptable. Antibiotic stewardship plays an important role in optimizing the use of antibiotics. As per CDC study, it is estimated that nationally more than 4.6 billion annually is spent to treat infections caused by 6 multi-drug resistant germs frequently found in healthcare. And it's very important to know that if no action is taken, the death toll because of AMR could rise to as much as 10 million deaths annually by 2050 and cause a 3.8% reduction in annual GDP. The challenge of detecting sepsis-causing pathogens is that the current standard, that is blood culture, is race against time. As time to result is on an average 2 days, varying between 1 to 5 days. Thus, there's reliance on empiric therapy, which we know is optimal in about 30 to 60% cases. To mention certain other challenges, the positivity rate with blood culture is low, the contamination rate is high, and it is also the administering antibiotics prior to culture or prenatal issues like improper specimen collection can alter the results. Based on the impressive work done by Kumar et al., we all are very well aware that each hour of delayed treatment increases mortality risk by about 8% during septic shock. I'm sorry. Here, the data from CDC is shown stating that more than half of the antibiotic prescribing for selected events in the hospital was not consistent with recommended prescribing practices. And prescribing can be improved through optimizing antibiotic selection, using the shortest effective duration of therapy, and reassessing antibiotic treatment when diagnostic testing results are available. Sooner the diagnostic test result is available, sooner targeted therapy can be started, which can improve hospital antibiotic usage and help fight antibiotic resistance, as per CDC. The time to appropriate therapy is a key driver of clinical outcomes, and the extended time from presentation to appropriate therapy remains a major contributor to poor patient outcomes and proliferation of antimicrobial resistance. The current standard of care, as we discussed, can take up to 3 days to provide the results, which can delay time-sensitive, life-saving targeted treatment. And prolonged use of broad-spectrum antimicrobial is a key risk factor associated with development and spread of antimicrobial-resistant organisms. Also, we know that rapid diagnosis and treatment could prevent as many as 80% of sepsis deaths. The left side of this slide is the time of sample collection, and it takes about 1 to 5 days to get a positive blood culture. There are many culture-based rapid diagnostic tests which can provide the species ID in 1 to 3 hours very quickly, however, only after the blood culture turns positive. These cannot be leveraged until culture becomes positive and cannot be utilized in cases of culture-negative sepsis. Culture-negative sepsis is a common clinical concern where the patient appears septic with a lack of pathogen growth on culture. And the non-culture based tests are not reliant on culture positivity or influenced by antibiotic intake prior to the test. T2 Biosystem diagnostic panels are the only CE marked and FDA cleared test that provides species identification and the only CE marked test that detects antibiotic resistance markers directly from whole blood and within 3 to 5 hours of the first blood draw. This just mentions quickly the differences between culture-based and culture-independent testing. As we mentioned, the culture-based tests, they depend on the blood culture positivity impacted by presence of antibiotics, may include resistance marker. The examples are FILMARRAY, PCR, MALDI-TOF, NAT, phenotypic and genotypic resistance markers, while culture-independent tests, their usage is dependent on the patient selection criteria, algorithms, provide opportunity to rapidly escalate, de-escalate, as there's no dependence on the blood culture turning positive. That time is very valuable. Resistance marker may not always be provided. Certain examples are next-gen sequencing, procalcitonin, and the T2MR-based identification. The culture-independent tests are simple to use, and the FDA-cleared T2DF instrument is a fully automated walk-away clinical multiplex benchtop. There are 7 individual random access drawers which can be loaded at any time. No batching is required. User-friendly touchscreen display provides step-by-step guidance to the operator to load a sample all in 10 minutes or less. So I would say in broadly, this is very sensitive. The limit of detection is as low as 1 CFU per ml, and the specificity is more than 98% across the panels. Talking about the T2 Canada panel, it covers the five fungal pathogens mentioned here on this slide, and these pathogens are known to lead to more than 90% of the invasive candidiasis. This is both FDA cleared and CE marked and has high sensitivity, as I already mentioned, and specificity of 99.4%. The T2 bacteria panel is designed for the detection of most of the escape pathogens, which are a group of infectious bacteria that have garnered particular attention for their ability to escape or evade common therapies through antimicrobial resistance. Escape pathogens are resistant against common empiric therapies. Escape pathogens remain a major healthcare burden. A recent study found that escape pathogens, when compared with non-escape pathogens, were associated with 3.3-day increase in length of stay, a $5,500 increase in cost of care, and a 2.1% absolute increase in mortality. The specificity of this panel is very high, 98%, and sensitivity is very high to 90%. This is both FDA cleared and CE marked. And to note, it's very impressive that T2 bacteria panel is the first in vitro diagnostic test to receive approval from US CMS for new technology add-on payment. The T2 resistance panel is not FDA cleared. It is only CE marked currently, and the clinical trial, a multi-center clinical trial, has been initiated. It's ongoing this year. It covers 13 molecular markers of antibiotic resistance, both gram-positive and gram-negative, and this is currently available in the US as research use only, while it is available OUS as CE mark product. And it is worth mentioning, like many other IVD companies, T2 also came out with the T2 SARS-CoV-2 panel with a very high PPA and NPO of 100%, and it detects all variants of SARS-CoV virus that are known as of today. It is available only in the US currently. The workflow of this test, you need basically 4 ml of the patient blood, load it into the instrument, and within the instrument, the cells are lysed, the target DNA is amplified, and the nanoparticles are clustered. The clustering is detected as change in T2 relaxation time of hydrogen nuclei in the sample. This is a proprietary methodology enabling inhibition-free DNA amplification in complex clinical matrices, and there's no background interference from either human DNA or antibiotics, and the pre-analytical process is really simplified by eliminating extraction and purification of DNA. And T2MR enables measurement directly from blood sample, enabling very high sensitivity. As it's well known that secondary bacterial and fungal infections, including the antimicrobial resistant infections, are likely to occur in a significantly high proportion of hospitalized patients with COVID. I did want to quickly mention a multi-center retrospective cohort analysis from 241 acute care hospitals of more than 590,000 patients evaluating COVID-19 and secondary infections. It showed that COVID positive patients were almost 2 times as likely to have a pathogen detected during the hospital onset period, and longer hospital stays and longer ICU stays for patients that tested positive for SARS-CoV-2 and secondary infection pathogen. And if you look at the table which is on this slide, you can see that the most commonly seen pathogens, secondary pathogens in COVID patients, are actually covered by the T2 panels. There is growing real-world evidence demonstrating positive impact of T2 Candida and T2 bacteria on patient care and antimicrobial stewardship. Across hospitals, we note reduction in ICU and hospital length of stay, faster initiation of targeted therapy, as well as discontinuation of antimicrobials and hospital savings. And in interest of time, I'm not going to the details, but you can see certain recently done prospective and retrospective studies are noted on these slides, which demonstrate this. And these have been done in US and out of US, these studies. A meta-analysis of 14 controlled studies was published in a peer-reviewed journal in May 2021, and it demonstrated that the time to detection as well as species identification with T2 versus blood culture was decreased by 3 days. There was faster time to targeted antimicrobial therapy for patients testing positive on T2MR by 42 hours, and faster time to de-escalation from empirical therapy for patient testing negative on T2MR by 7 hours. Shorter length of ICU stay and hospital stay by 5 days. And this shows the recent clinical data on T2 resistance panel. Again, here what we can see is that this demonstrates higher sensitivity and specificity, faster time to result, escalation and de-escalation of antibiotics. And these are also recent studies which have been done OUS. And I would want to, before I hand over to Dr. Snyder, I just wanted to conclude by saying that rapid diagnostics in sepsis management is critical for timely initiation of targeted therapy, and currently available culture-independent technologies are innovative and can improve time to result and ultimately patient outcomes. Blood cultures remain the gold standard for diagnosing bacterial and fungal bloodstream infections, but are limited by slow turnaround time and sensitivity. The limitation of blood culture and the quality standard for sepsis lead to aggressive empiric broad-spectrum antibiotic therapy, and this practice may result in unnecessary antimicrobial use, toxicity, and antimicrobial resistance. Culture-independent rapid diagnostic test that detect pathogens directly from blood can transform clinical practice by decreasing resource utilization and improving clinical outcomes. Understanding of how to incorporate these innovative tests into clinical testing and treatment algorithms are necessary for successful implementation. And handing over to Dr. Snyder for discussing more of this. Thank you.
Thank you, Aparna. And welcome, everyone. We're going to be talking more about the real-world experiences that we've encountered since adding this particular technology to our service. These are my conflict of interest. About 8 years ago, we decided that rapid diagnostics would be our primary driving philosophy in moving our laboratory forward into what I call the technology era, specifically the cutting edge technology. So what has driven this concept to drive our laboratory forward? Well, obviously, it's important that we should be able to not only accurately, but quickly diagnose, laboratory diagnosis, infectious diseases. Obviously, excuse me, okay. Culture remains as the gold standard, of course, but it has low sensitivity. And it also increases our turnaround time to generate final results. We need to influence through antimicrobial stewardship, the initiation of appropriate therapy, specifically targeted therapy, in our efforts to reduce morbidity and mortality. As I said, very much a part of the antimicrobial stewardship program, usually with empiric therapy initiated, maybe stay on for 3 or 4 days. With rapid diagnostics such as T2, we've been able to demonstrate that they get more targeted therapy or even discontinue therapy. And all that adds up to money, of course, of which the administrators like to see. And we also like to promote unnecessary use of antibiotics as well as antifungals, reduce poor outcomes, reduce length of stay, and yes, readmission, which we define as 30 days after discharge, but being readmitted for the situation that they were initially admitted for. And then I emphasize once again to support the sepsis program. Very, very important. Aparna went over the targets that the bacterial and Candida panels have. I will not belabor the point here, but we have both T2 bacterial and T2 Candida. We also have diagnostic stewardship activity in our institution. And anytime we bring on a new service, we try to determine what is the optimal use for this type of technology. So in regards to the T2, the testing is restricted to high-risk patients. And that's based upon the fact that our epidemiology clearly shows this is where you're going to find the majority of your pathogens, both Candida as well as the bacterial. So we have identified the intensive care units, the transplant patients, both solid organ and bone marrow, our oncology patients, and the emergency rooms. So these were our targets to limit, if you will, or to restrict testing to the areas where you're going to have the highest return on your investment. Also, the training of phlebotomists is very critical, and I'll say more about that in a few moments. In situations where nursing is drawing blood cultures, they have to be trained, and even the clinician should be aware, not necessarily draw, but sometimes the clinician does have to draw a blood specimen for culture, and maybe in this case T2. And as mentioned previously, the samples of 3 to 4 mil separate tube, and I emphasize a peripheral blood only, no line draws, and blood culture must be collected simultaneously at the time of the T2. So we collect the blood culture, we collect the T2 at the same time. Once again, a separate container for the T2 sample, and then our standard 20 ml blood volume draw for our blood cultures, aerobic and anaerobic. Now, I should share with you that we started looking at this over 5 years ago. And as a result of that, we were hindered quite a bit by the hospital being under a private management company who resisted moving forward with technology such as the T2 because of what they felt were costs. So we put together a multidisciplinary team with the idea that they could influence the acquisition of the instrument for use in our service. 3 years, or let's say 3 years ago, the private company was replaced by a separate university-based group. So we are a private individual account, if you will, in which the team approach has been very effective. So in our approval process, beginning with verification, et cetera, we did our cost analysis, including our direct costs, were reportable. We estimated the savings to the institution based upon antimicrobials and length of stay, and had the cost of 1 day in the intensive care unit and the others, and we used those as our financial foundation to justify our costs. Test verification data was generated. We also provided literature support in terms of working with the administration. We also had to look at with the impact on workflow. We were fortunate to be a 24/7 dedicated microbiology staff, and workflow has not been a problem. And these tests are done as soon as they come in, i.e. stat, around the clock. And then we obtain letters of support from our major team players, pharmacy, bone marrow, pulmonary, and so forth. And as a result of that, all these added up to us being able to present and acquire the instrument for use. So once it was decided that the instrument was approved by the administration, we now needed to implement it. And it started with the training of the phlebotomy team, of which the company was very good in terms of their support. They also trained the nursing personnel. And I should inform you, we are a network-based core laboratory. We serve 8 facilities in our region, 4 of which are hospitals. And once again, these people have been trained. We're waiting to train 1 more hospital, just came aboard in the last year. But the key was, or the goal was, is to promote uniformity of the sample collection. The laboratory staff is not only, but also, of course, for round-the-clock coverage, we trained 4 individuals to run the T2 system. We created an electronic order as well. And in that order, we have T2 plus blood culture. The purpose of that was to remind the ordering physician, if you want a T2, you also have to have a blood culture. We would not accept a T2 sample without an accompanying blood culture. We will give them 45 minutes flexibility from the time the T2 is collected to the time it's a blood culture. But if it's more than 45 minutes, let's say an hour, the T2 test is rejected. But once again, it's been a learning environment, to say the least, but we are seeing more and more our medical staff becoming comfortable with how to order it and what is needed. We call positive results immediately to the ordering service, including the pharmacy. And once again, we place great emphasis on the importance of that T2 sample being accompanied by a blood culture. I wanted to put this up here because we were having problems with blood volume, and you can see in this tube, what we did was fill several tubes with methylene blue up to 4 mLs and distributed those to the respective services to use as a guide in collecting the appropriate volume of blood necessary for the T2 testing. We also require an extra T2 tube to be collected with the order to ensure that we have a backup in the event that there is a technical problem or possibly an underfill in the original tube. So if you order a T2 Canada, 2 tubes. If you order a bacterial panel, 2 tubes. As a result of that, it's starting to work very well, but this is one of the learning situations we had because there is turnover in nursing, there is turnover in phlebotomy. So it's a constant reinforcement to ensure that the uniformity standard that we tried to set is maintained. This particular slide gives us a lot of information because there are invalids, especially on the T2 Canada. And each of these categories, the sample check, the procedure check, and the interference check is very, very important. We have a pathology resident right now investigating a few invalids that we have encountered and looking for whether or not any of the substances that you see listed here are in the patient's history. And one thing we've noted on a couple patients was they had an MRI with contrast, and of course contrast can interfere and give you negative results on the T2. Matter of fact, the bone marrow people have this posted up in their unit to remind their nurses because they draw all the blood specimens, that is the T2s in this case, and the blood cultures. So once again, the procedure check is very important. That's more pre-analytical as it applies to the laboratory in addition to the sample check. So the far right-hand column here, the interfering substances check, is very, very important for your providers to be aware of. And once again, we reinforce that periodically. So our suggested ordering protocol is listed as follows here. Oncology and transplant services, we recommend ordering a T2 Canada panel only because fungemia is very prevalent in those patient populations. The ICUs, we recommend a T2 bacterial panel be ordered. The emergency room, where we see a lot of our volume, we recommend T2 bacteria panel. And then infectious diseases can order whatever they want. But once again, if they order both bacteria and Canada, we have to have at least 2, 3 to 4 ml samples. But since then, we've added that extra tube on to ensure that we up in the event of an error, technical breakdown, or something. The option to order both panels, yes, they do have that option. The results in 3 to 4 ml samples are accompanied by a 20 ml peripheral blood culture. So a physician can order both, but in our suggested ordering protocol, we have shared with them, this is where we see the highest return on our testing, given the type of patient population. And it supports the concept of diagnostic stewardship very well. So that backup specimen we find is very, very helpful. It's rare that we have to use it, but we have it there in the event that we have a problem. And just to show you some data, you could say, well, we don't have a lot of numbers. Well, this is 2 months worth of data. And you can see the sensitivity of the T2 in the bacterial panel is higher than that in the blood culture. So once again, for the targeted organisms, the T2 panel is very good, and it also has, as it will for the Canada panel, high sensitivity. And the other thing that we looked at was the negative predicted value. And the negative predicted value is very high. So what does that mean clinically? That simply means that if it's negative, you could possibly stop therapy. That's the clinician's decision, but at the same time, we feel comfortable saying you might want to consider terminating therapy. And this is where we work with our pharmacists and the PharmDs who are on the units that can influence this on each of the respective units that they cover. But once again, the Canada and so forth, as you can see here, the different species, we did pick up through sensitivity on the T2, the Canada albicans tropicalis and parapsilosis. Matter of fact, we had a parapsilosis just before we went live this morning, and bone marrow called me and said, should we believe this? And I said, of course, and the patient is now on the appropriate targeted therapy. So that gives you an example of the influence and impact that the laboratory can have on the patient management. We also get other positives that are not in the database, and this is some of the, or represents some of the organisms that we have recovered phenotypically in blood culture that obviously are not detected in the T2. So we look at the T2 as a screening test. We also look at it as a supplement to our phenotypic blood cultures, et cetera. And this slide clearly points out the other organisms as you can see. Now, the Canada species obviously was recovered, but it was not detected by the T2 because of the specificity of the T2. So once again, these organisms are not in the database, and as a result of that, it says the T2 will supplement the blood culture, and phenotypically, it's very, very important to realize that. Now, I will say that physicians continue to be, although they're starting to come around, and they have been trained this way to rely on phenotypic results. So genomic results such as the CT, they're somewhat nervous about it, but as we learn and gain more experience and share that with them in our studies, they're beginning to become more comfortable with the T2 results. And just like the T2 results that I shared with you a few moments ago with the Canada parapsilosis, that immediately initiated targeted therapy for that particular patient. So we will follow up and see how it came out. Will we get T2 negatives and culture positives? Occasionally. Well, this is an example right here on this slide, T2 negative, culture positive. And once again, that's why I reinforce the fact we look at it as a screen and a supplement to our standard phenotypic culture and antimicrobial susceptibility, as well as antifungal therapy when we do our fungal susceptibility testing. I want to thank Sierra Spillman, one of our young, aggressive, very involved medical technologists who has put the previous data that I showed you together, and she sent me another load of data last night, of which I've not had an opportunity to look at, but I'm sure it's going to be very, very informative with regards to the activities that we're seeing with our T2. I forgot to mention earlier that in our justification, we also included the CPT codes that are assigned to the T2. Now, granted, CPT codes are used for reimbursement of outpatients, and all these cultures or testing we're referring to here are inpatients, which are DRG, but we use the CPT codes to monitor our staffing needs, and with the reimbursement from these respective Canada and bacterial panels, it adds value to our staffing situation, which has been supported greatly by the data that we present them to show them our workload. But once again, there are CPT codes. We can discuss that later if anybody has any questions. But I will now turn it over to our next speaker, and thank you very much.
Thank you, Dr. Snyder. And let me add my warm welcome to the attendees, and I'm delighted to be with you to share with you how choosing wisely drives change to innovative technology for high-value patient outcomes. Shown here are my disclosures. During our brief time together today, our objective is to describe how choosing wisely can provide an effective framework for driving clinical practice change for those high-value patient outcomes. Let me tell you a little bit about Mather Hospital Northwell Health. Mather is a 248-bed not-for-profit teaching hospital that was established in 1929 as the first community hospital in its area. We're located in New York State, about 65 miles east of New York City on the North Shore of Long Island. And Mather has what we call many specialty signature programs, which are continually changing to meet the health care needs of our community. In 2008, we began our Voyage to Excellence initiative with the mission of being the best community teaching hospital in New York State. Our laboratory is New York State and Joint Commission accredited and performs about 2.4 million tests per year. Our hospital has been recognized for excellence in patient safety. We've also received magnet status from that institution for nursing excellence. And in December of 2017, Mather became the proud member of Northwell Health, making it the largest network within New York State. And in 2021, ASCP recognized our Choosing Wisely committee as a Choosing Wisely champion. In January of 2016, colleagues from all areas of our hospital were invited by the medical board to join our Choosing Wisely initiative. The invitation provided background information regarding the Choosing Wisely initiative of the ABIM Foundation and over 26 subspecialty societies. Each society has published a list of guidelines that are relative to their particular subspecialties in order to provide guidance to physicians and their patients about the appropriate use of tests and procedures. For Mather, our high-level goals for this multidisciplinary team include review of evidence-based guidelines to stimulate discussion about frequently ordered tests and/or treatments, and to develop tools to ensure clinicians make effective care choices, thereby improving quality and enhancing patient outcomes, while also optimizing healthcare resources. It was really here that we knew the laboratory could be a critical contributor to this initiative because we do provide crucial information to clinicians for improving prevention, diagnosis, treatment, and management of the patient. Just this year, we updated our mission statement shown here, and it has three main elements. The first, to foster evidence-based medical practices in all possible avenues at Mather Hospital. Two, to reduce wastage of resources by advocacy of value-based care in Mather Hospital. And three, to promote free and open scholarly discussion on any subjects pertaining to either of the above aims when necessary. So these really cover all the pillars of our Voyage to Excellence. If we look at our Choosing Wisely objectives, they're simple. We want to have better matching of patient care to the appropriate level of patient needs. It must also be of high value with specific attention to the needs of specific patient populations and their specific clinical conditions, such as diabetes, heart failure, sepsis, and renal disease, just to mention a few. Also, by looking at guidelines and implementing evidence-based medicine, we can change everyday standard practice to meaningful science that will lead to more effective patient care, treatments, and outcomes, thereby eliminating the overuse of ineffective care. But I like to say, if only changing clinician behavior was this easy. Some of the key performance indicators of our initiative for Choosing Wisely include identifying a challenging issue or recognizing an opportunity where we can improve the process and quality, but most importantly, there must be a patient benefit. The change must improve patient safety and enhance patient satisfaction, improve patient outcomes by decreasing length of stay, reducing mortality, and significantly decreasing hospital-acquired infection and readmissions. And additionally, want to avoid unnecessary tests and treatments while delivering the appropriate level of care and optimizing healthcare costs. Some of the key questions to consider when looking at proposed initiatives include, can patient outcomes and satisfaction be improved? Can we demonstrate measurable outcomes? What are the potential savings? Can clinical practice be changed? Well, we believe the answer to all of these questions are yes. Well, it takes a village collaborating together to make things happen successfully, as Dr. Snyder pointed out. And as you can see from this list, that our committee represents clinical departments, clinicians, nursing, finance, and the C-suite, making it truly a multidisciplinary committee. Shown here and on the next slide are some of the initiatives that we've encountered over the last 5 years. And these initiatives are in the diagnostic testing space of not only the laboratory, but also imaging. So now let's turn our attention and looking at how leveraging innovative technology like T2 can assist us in the battle against sepsis and support our initiatives for our sepsis task force. You've already heard about the bad boys, the escape pathogens. Shown here are 5 of the deadly bacterial pathogens that are associated with over 90% of sepsis cases, as well as these ones as possessing multi-drug resistant properties. Together, they're collectively known as the escape pathogens. You've already heard they cause over 2 million illnesses and over 23,000 deaths per year, according to CDC. We know that they're also the leading cause of hospital-acquired infection, and infection with one of these pathogens in the bloodstream is associated with increased mortality and death. So for our committee, the first data analytic metric that we wanted to look at was, who is our key stakeholder? Who could we identify as our champion partner based on the frequency of blood cultures ordered? And you can see here very quickly on the graph, the standout orderer, number 1 ordering department is the emergency department. The ED represents 70% of the orders, followed by internal medicine at almost 18%. Based on the fact that the ED was our number 1 blood culture user, we wanted to take a deeper analytical dive and look at some data metrics regarding positive blood cultures and what pathogens were identified in a 6-month period. And that period of time was from January 2021 to June 2021. The results were that there was a total of 4,103 blood cultures ordered by the ED, and of those 4,103 blood cultures, 248 blood cultures were positive for a pathogen. During this 6-month time period, the blood culture contamination rate was 1.75%, or represented 4 blood cultures, leaving us with 244 positive blood cultures. Of these 244 positive blood cultures, we wanted to see how many of these positive blood cultures could have detected a bacterial organism using the T2 bacterial panel. A review of the data reviewed that 142 blood cultures could have been identified as having a pathogen on the T2 panel. So our analysis further revealed that 58% of the total positive blood cultures could have been rapidly identified with one of the 5 sepsis-causing pathogens using the T2 bacterial panel with a single blood tube collection. Also, the T2 results would have been available to a clinician at least 24 hours earlier than the traditional blood culture results, and there would not be any interference from antibiotics on board the patient at the time of draw. And third, we could initiate targeted antibiotic treatment at least 24 hours sooner, which can lead to high-value patient outcomes. I know this was one of the poll questions in the beginning, asking you if you know what is the most common pathogen in your organization. And I have to tell you that before this retrospective review, it was not really clear as to which pathogens we were actually seeing. And you can see here that the breakdown of those 142 ED positive blood cultures, it actually represented 88 unique patients. And our number one pathogen was E. coli, followed by Staph aureus and MRSA, followed by Klebsiella pneumoniae, Pseudomonas aeruginosa. And no one really thought that we saw much Enterococcus faecium, but we actually had 2 patients. So it really brought to the surface what we were seeing in our specific patient population. So my question to you is, who wouldn't want to know if a patient has an escape pathogen in 3 to 5 hours with a single blood draw? If we look at performance characteristics for the gold standard, which has traditionally been the blood culture, and compare it to magnetic resonance technology, you can see that the magnetic resonance technology with a sensitivity of 90% and specificity of 98% outperforms the traditional blood culture. The sensitivity of blood culture is overall low at 50%, and that's partly because blood culture depends on the blood volume drawn, the timing of the blood draw, whether the patient has had any prior treatment with antibiotics, as well as the presence of a viable organism. Additionally, contamination results are responsible for more than 1.4 million patients per year having false positive blood culture results, and this leads to misdiagnosis, which then can lead to unnecessary antibiotic treatment, extended hospital stays, and increased mortality and cost. The value of the T2, shown here is the recommendations from our Choosing Wisely committee, and we chose to target high-risk patients who are presenting to the emergency room. So to start off our journey at our institution, ED clinicians may order a T2 bacterial panel for patients who are presenting with clinical signs and symptoms of bloodstream infection and/or sepsis, or at risk of progression to sepsis and starting empiric therapy. That also must be followed up by infectious disease consultation. So we believe that the value of a T2 bacterial panel is unquestionable and that it saves lives and dollars. If we look at the cost of $140 to the laboratory, the value that we receive back is that we have rapid direct genus and species identification with no antibiotic interference in less than 3 to 5 hours with a single blood draw. As you heard from Dr. Snyder, this also promotes antibiotic stewardship. It then allows for de-escalation of antibiotics by the PharmD in consultation with clinicians, and it enhances patient care management by changing broad-spectrum antibiotic to targeted antibiotic therapy, thereby improving patient outcomes and providing high-value outcomes for our patients. Well, what lessons have we learned? Well, there are many, and there's even been some bumps along the way. But first, it's paramount to continue to have assessment of all of our initiatives, otherwise progress and performance can drop off significantly. It's also important to keep lines of communication open, which is critical between all stakeholders. We also have found that data analytics play an essential role in everything we do. And additionally, that information technology can assist with hardwiring of changes for sustained use and successful metrics. We also realize that change is slower than expected, especially in a COVID world today. And it's important to have patience and recognize and celebrate the wins. As I said, collaboration among all stakeholders is paramount for success, and understanding everyone's strengths and weaknesses is also important. Who better knows the strengths and weaknesses of our test than you, the laboratorian? So it's an opportunity for us to step up, bring value, and provide education, information, and guidance to clinicians for enhanced clinical effectiveness, thereby allowing us as laboratorians to be part of the integrated healthcare delivery team. And finally, be prepared to make the journey and shift from volume to more of a focus on value. And finally, remember there has to be something for everyone among all the stakeholders, and especially for our patients. With that, I'd like to conclude with choosing wisely can provide an essential and strategic framework for implementing T2 testing panels. An implementation of T2 can demonstrate how the laboratory can directly contribute to enhanced patient care and outcomes by implementing advanced innovative technology. And with that, I'd like to thank you and turn it over to our moderator.
Well, thank you, Aparna and James and Denise, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have any questions, audience members, please ask now. Just click on that Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. So let's take a look. We already have some great questions coming in from our audience. Our first question is for you, Dr. Snyder. Are the blood culture instruments located at each hospital or only at UL?
Each institution has their own blood culture instrument. However, we're trying to standardize that where we use and select one instrument only. Currently, we're diverse, and that's a direct result of the transition we're undergoing right now. But what they will do is send the positive blood cultures to us for full workup. I also ask them to make a gram stain and send an unstained smear to the laboratory so we can validate or verify what they initially reported on site.
Thank you so much. And Dr. Ahuja, what is the change in sensitivity with lower draw volume of, let's say, 2 milliliters versus the 3 or 4 that's recommended?
This is a great question and a very practical, I would say, challenge which can be faced by labs. So the good news is that the test actually utilizes and processes 2 ml of blood. And so if the volume is up to 2 ml, there's no impact on sensitivity. We have data to show that. So I hope that answered the question.
Thank you so much. And Dr. Uettwiller-Geiger, I've got a question for you as well. Our next question, why did you focus on collecting data from the ED?
Well, we found that the emergency room was our #1 orderer of blood cultures and thought that having rapid, accurate diagnosis of sepsis for the emergency room would be most important. 80% of our admissions occur from the emergency room, and we thought that was a good start point in our specific patient population.
Thank you so much. And I actually have another question for you as well. How does T2 meet your choosing wisely guidelines?
Well, I think that when you look at choosing wisely and wanting to bring high-valued patient outcomes and to a specific patient population, and given sepsis is a specific patient population that's associated with high mortality, it definitely met the criteria for wanting to bring and leverage innovative technology for that rapid and direct detection of genus and species for our patients.
Thank you so much. And this next question I have is for Dr. Snyder. Dr. Snyder, how has T2 affected your lab workflow?
Excuse me, I'll get I apologize for the interruption. How has the T2 affected our laboratory workflow? Well, we have it in the molecular laboratory, and the staff there around the clock to our initially we had to find out how many people do we need to cover the 24/7. Once we did that, the workflow has not really been a problem because they know that when it comes in, it's a stat test and they process it immediately. And so overall, it's not been a problem.
Thank you so much. And again, I want to thank our audience for these great questions coming in and remind you that any questions not answered will be answered via email today. We have time for one more question. What is the footprint of the analytical instrument, and does it require any special additions to the room where it operates, such as shielding? Also, an approximate cost.
Thank you for that question. So the instrument, the footprint, I would say, of T2DX, the width is 102.9 centimeter, the depth is 62.2 centimeter, and the height is 72.4 centimeter. The room where it's placed, typically the hospitals, and I'm sure Dr. Snyder and Dr. Geiger could add to it, the labs typically have it either in the molecular lab or the microbiology lab, and we do not recommend any shielding or anything in specific. However, it needs to be away from the HVAC ducts, direct sunlight, and water sources or culture benches. And the room temperature should be 20 to 25 degrees centigrade and humidity 85% or less. That's the requirement. And the other question was about the cost, and I think that's something that none of the lab leaders or clinicians should worry about, because that's a discussion you can do with the company, T2 Biosystems, and our team can address that. I would steer away from mentioning the cost, because that should not be the concern about what is the cost of the instrument. I can just say that the cost is not enough for anyone to have a concern. I'll leave it at that.
Dr. Ahuja and Dr. Snyder and Dr. Uettwiller-Geiger, I want to thank you for your time today and for your important research. And before we go, I also want to thank LabRoots and our sponsor, T2 Biosystems, for underwriting today's educational webcast. And before we go, I want to thank our audience for these great questions and for joining us today. Questions we did not have time to answer today, and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. And this webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Bye-bye.